Hi, everybody, and welcome to DocTalk. I'm Dr. Erin Knopf,
I'm Dr. Corrine Hannon.
I'm Scout
and today we are.
Silverstein.
Oh, thank you. I was ready to introduce you, but you jumped on in. Everybody, we have this really special guest with us. Scout Silverstein, they them pronouns, is a specialist in gender affirming eating disorder care. They provide training to healthcare professionals, consultation to clinicians, and coaching to parents of transgender youth. And I'm so excited because today is National Coming Out Day, and we're going to talk about some really practical and important information that anyone could benefit from hearing. So, Scout, thank you for joining us. It's an honor.
Of course, thanks for having me.
Okay, so where should we start? I mean, we know there are so many layers to really pull back, but if we get really foundational, I
Well,
wonder
let me
if we
say one
can.
thing too. We're
Oh,
recording on October 11th, but when you watch this, it may not be National Coming Out Day. But just for reference, October 11th is National Coming Out Day. So we're going to talk about coming out. Is that Go
yes,
ahead, Dr.
perfect.
Knopf.
No, that was perfect. Thank you. If anything, I'm curious, Scout, when you are working with parents and individuals, what if you had to define, the first concern they bring up around gender affirming care? What does that look like? And what are the nuances in that conversation you really try to impress upon them?
Well, I'm going to scale it back just a
Ooh,
second to talk about the themes that come up, regardless if it's about gender or sexual orientation. What I experience the most in speaking with families is fear and uncertainty. And those are both things
mm,
that we all have experience navigating. It feels unique or distinct because it's something that people are perhaps unfamiliar with, but it's helpful to understand the coming out process and to also understand when we're thinking about the unique stressors that LGBTQ people experience, that coming out doesn't frequently tend to be a singular experience. Typically, people come out multiple times, whether it's to different people in their life at a single point in time or as they understand new parts of their identity. Coming out could be something that happens across the lifetime. So it could be helpful to understand the coming out process as having 5 stages. Someone recognizes in themselves that they have this new understanding of their gender identity or sexual orientation. It's coming out to self. Then, typically, especially for younger people who feel safe doing so, there's a coming out process to caregivers or to important people of influence in their life. Once that happens, there tends to automatically be this relational tension, even if the person that this person came out to is accepting and positive. There still tends to be tension because there needs to be adaptations that are made, or people need to essentially learn new skills or new ways of talking about someone, or new aspects of this person's life as they recently came out to themselves. So that's when people then go into this relational adjustment with one another, where they're making these adaptations, learning how to better understand one another and talk about this experience. And after that happens, there's essentially an ongoing, evolving relational identity between the two people.
mm.
So, in understanding that coming out process, that gives us tools to then um, essentially help caregivers work through the tension that they're experiencing or the lack of skills they may have to support this person in their life.
So
I
the
really love how
relationship
you
goes through
go ahead.
tension, adaptation, and then a new identity of that relationship. Is that what you're saying? Okay.
Yeah, and I guess I should also, since this is a talk for very, include some correlation to eating disorder symptoms or disordered eating, which many people will experience when they're navigating experiences of tension, of fear, of uncertainty. Someone may use eating disorder behaviors to emotionally regulate through this process, or to feel more in control of their life when they're going through these big changes. And for the myriad of reasons people use disordered eating behaviors.
Yeah. Oh, I really honestly, I love how you named the five stages too, because I think it's really important to see how normal that process can be. Because I think a lot of people get scared first and foremost of that relational tension. There's a lot of catastrophizing. There's also a lot of lived experience around how family members, friends have reacted when attempting to have the conversation. But I also like how you talked about the tension could be from a positive lens where someone is trying to show up for their loved one fully and completely, but change is hard and change feels awkward. And so tension or awkwardness is a form of tension. Um,
Well, and
but
that
that
all
there
change
is a
has a
sense of,
developmental curve, right? All change takes
yeah,
time, even if it's affirming, even if it's supportive, that it makes sense to give it time and like
yeah.
renegotiate what this looks like and be curious. Is that kind of you mentioned open-ended questions. Are there kind of tips that you give to caregivers, to therapists, to clients about that?
Yeah, I'll go through the communication cycle that I've developed in working with caregivers that maybe aren't as affirming as we would wish them to be. I want to preface this with an example of what positive relational tension can look like. Um, this is grounded in my own lived experience, this example, where maybe my first 2 years of being out as trans, my gender identity and gender experience was the most important aspect of my life and the most central identity to me at that point in time. I didn't come out as trans until I was 29, which sometimes I look at Instagram and these social media sites, and even when I go to trans spaces, I'm considered an elder. I'm now 37, and I'm like, that's kind of wild. And I have a grandmother who's always been very supportive. She's like, I don't care what your name is. You'll always be like my grandchild. She knows what they, them pronouns are. I remember about 3 months after I came out, she told me she was watching I Am Jazz on TV to better understand the trans experience. Um, our relationship has remained supportive and positive. Now I've been out for, I don't know, 29 to 37, 8 years, 8.5 years. And being trans is one of the least interesting or salient things about my identity or my daily life. But I still find that, you know, my grandmother will misgender me and I'll correct her. And it will be this whole kind of like meltdown spiel about how she's so sorry. And it takes her 3 minutes to apologize. And like that is an example of some relational tension where it's not that we have beef with each other or that like it's a negative kind of interaction, but like I've moved past the stages, I've evolved, and like she's at a different place in that process and like her relationship with me, and that's fine. It's overall a very like positive experience. However, I've had some other experiences, and I see this all the time in clients and their caregivers, where someone may be stuck on a skill like gendering someone correctly, and they may be in their 3 minute apology, and in that apology you hear how much they love you and that they don't mean to screw it up, but they've just always used this language and they're of a different generation, and they them pronouns as a plural are very confusing. And so in that setting, in that situation, this is where my communication process comes in. It starts with validating emotions for the person who's struggling. This is without validating the biases. So it would be, I hear how difficult this is for you. I hear how much you're struggling with this. Like that can be a very distressing experience. I want you to know that you're not alone. A lot of people struggle with this. And then you kind of keep that short and not give, the amount of space this is taking up even more airtime. And you share evidence-based information. And this is a little bit of a balance. I feel like typically in the mental health field, we hear so much data about suicidality and gender dysphoria and all of these kinds of negative aspects of gender diversity. So it's a balance. One balance here might be, or like one side of it, maybe, we know that using someone's affirmed and asserted pronouns increases their sense of belonging, increases their quality of life. That would be like a strengths-based way of sharing it. We also know that using someone's affirmed pronouns decreases their rates of depression and suicidality. Because I'm like, I really don't want to get people into this place where we're just like scaring them with the evidence. And then once you share that evidence, hopefully that increase some motivation for behavioral change of, wanting to use someone's pronouns. And so you would maybe ask an open-ended question, like, at this point in time, what are you finding difficult about the process? What is keeping you from practicing pronouns? You know, it's been a few years, or it's been a few months, or even a few weeks. You've known that this person is using different pronouns than you're used to, and you're still struggling. So can you explain to me what the struggle is? And they do that. Again, you could cycle back to validating emotions, and then you want to provide encouragement. And I always ground this in like very similar kind of phrases, because most of the time they're like pretty universally true of, I know how much you love your child. I could see how much you care about your child. And you start with that strengths-based perspective and build on it to provide encouragement. And then before you end the conversation about this, you make sure you give some resources to the person for continued learning or for connecting with other parents or caregivers of transgender youth.
Beautiful.
I also, though, just want to name the power there. And also, maybe this is a negative, or it feels like I feel sad about it. But like, there has to be so much like, let me caretake this other person who's not the individual going through the journey of being in a marginalized identity and being, seen as a pariah by so many social constructs out here. It's like, oh, okay. That's a lot of energy that you're doing just on helping them feel safe and comfortable. And I couldn't help but name that. I'm grateful for
It's
the
a
work you're
lot, but
doing.
it's of service to the person who is marginalized, right?
True.
And also, like,
True.
we don't know, right? Like, gender diversity applies to all people. We talked about this
Totally.
before the call, but like cisgender people have diversity in how they express their gender, for example. Like, not all women are hyper feminine, not all men are hyper masculine. You never know if, like, by a parent supporting their trans child, they'll be able to kind of reflect and introspect, and they may end up realizing that they are a non-binary woman, or that like they don't feel as um, strong about subscribing to the gender norms that they were conditioned with. And I've seen that in a lot of families, that like the LGBTQ community, a lot of times when like a child comes out early, the parents end up doing a lot of identity exploration themselves.
Yeah. I mean,
Uh,
our
Yeah.
social constructs are powerful.
Yeah, and like I love what both of you brought up. Like I've seen that in my clinical work as well, that a lot of time the client that I'm working with has to do kind of a double labor, right? Of like both doing their own work and then teaching their loved ones how to interact with them. And so in one sense that might be unfair, but it's also just part of being in a relationship, and it's part of hopefully improving that relational identity or getting through that tension, as you said. I also just had a quick question for those that aren't familiar with like the apology process when people misgender. That, I was taught, and I want to check this out with you, Scout, too. If someone corrects you, you just say, "Oh yeah, thank you," correct it, and then move on. Is that,
Correct.
yeah.
Yeah.
Versus make it a huge emotional, dramatic exchange, unless that is somehow appropriate. But I don't know if that would ever be
Yeah.
appropriate.
I mean, if you think about it, like every time you misgender someone, to that person, it may feel like you just scalded them with the flame or something. And then the more energy and time you take to apologize and explain for it, it's like putting more of a flame into it and making it a bigger fire. And I'm like, if you just burned me, I don't want you to burn me more. Like, I
Oh,
recognize it was an accidental burn, and let's move on. And hopefully in your free time you could interrogate what you conceive someone with she, her, or they, them, or he, him pronouns to look like, what the implicit biases are that are baked in there. And you could practice. Like, one of the tips I give people who struggle with they, them pronouns is like, for 3 days, use they, them pronouns for everyone you interact with. Once it's rolling off the tongue and you have like the body memory of doing it, it'll be a lot easier to do it after that.
it's a
I
great
also think I
practical.
just use that for everybody now too, in general. You bring up a good point too of how can we not traumatize people, for those of us that are in this work, those of us that are supporting people who are finding themselves, with these identities. How do you talk about gender, and what do you recommend to people when they're talking with their loved ones or their clients in a trauma-informed way?
Yeah, before I go into like some prompts that you can internalize and try to use in sessions, I love this quote in A Clinician's Guide to Gender Affirming Care, which Annalise Singh and San Chang co-authored along with one other person, and I apologize for not remembering their name. But it essentially says a trauma-informed approach to working with trans clients requires not only attunement and understanding of the signs, symptoms, and effects of trauma, but also responsiveness to the ways that trauma can be treated or healed or worsened in the course of therapeutic work. So keeping that in mind, that like what we do matters, not that I want anyone to stress about or like obsess about or fixate on causing harm, because it's inevitable that harm will occur in relationships in general, but to understand that we have a responsibility to do our own research and continue learning so that we minimize the chances of doing harm. Once you're in the room with someone who is maybe somewhere in this coming out process, inviting that conversation into the room can be really helpful, especially thinking about people with eating disorders. I frequently think about modalities like TBTS and RODBT that use personality traits as a basis for understanding eating disorder behaviors or eating disorder kind of like neurotypes. And often in those, we think about over-controlled or under-controlled people. And I'm kind of like, there are many people who will not voluntarily bring up a topic in the therapy room unless it's brought up or invited in by the therapist or clinician. So one of the prompts that I really enjoy is it okay with you if we discuss some of your beliefs about how your experience with gender is connected to your relationship with food and body? And I love this one because it's not talking specifically about gender diversity. And many, many, many of the things that we're doing under the gender affirming care umbrella apply to all people because we all have a gender. If at any time you want to tap out of this conversation, you are in control. Where I had a friend recently that was having a lot of stress about talking about their gender with one of their clinicians that they see. And we ended up discussing the possibility of just bringing up the stress to the clinician so that they could talk through what the limitations are, what boundaries they might want to put in place, consents. They could kind of negotiate the process of talking about the heart of what this person is struggling with without immediately jumping into it.
Wow.
That
I
just
also
feels
love
like
this
golden.
graphic. Sorry, this Planned
Oh,
Parenthood graphic I love. Talks about consent with the acronym FRIES, like French fries. Consent is freely given, reversible, informed, enthusiastic, and specific. So if
Ooh.
someone in one session comes in and you end up talking about how they're questioning their gender identity, it doesn't automatically assume that the next session, the same kind of environment is going to be created or comfort level of diving back into it. So checking in each session, or if someone shuts down completely when you bring it up, maybe in another 3 months when you're still seeing this person, has anything changed?
Wow.
that is beautiful. I love that acronym. And I feel like I love that this is recorded because that right there, that gem is something that I, in listening to this, will rewind and listen to over and over again. The phrasing and the acronym both. And it's such a good reminder for everyone, because like you said, everyone has some dimension of gender that interacts with food and body. Like no human being escapes it. It applies to all of us, whether we're disordered, non-disordered in our relationship with food. No matter what our relationship with gender is, this is going to affect us. And there's such good questions. And it's so important to have consent and ongoing consent and not to assume that consent is ongoing. I love that.
I also have an exercise that it's an implicit bias exercise from that book I named, A Clinician Guide to Gender Affirming Care. And I usually do this exercise when I'm training clinicians, but I think it's useful for every human to do. And so I'm going to read the questions. And if you want to just pause the video after I read each question and reflect and then unpause, I really, really recommend you do this every time I deliver these questions. I do it myself. And without fail, I have implicit bias, even as someone that is gender diverse and loves gender diverse people. So the three questions are, what biases about gender or transgender people do I have? And it's after doing this exercise. Sorry, I read it backwards. Imagine in your mind a man and a woman. Hold those pictures in your mind. Notice what physical or personality characteristic these imaginary figures have. Notice the racial or ethnic background of these figures. Notice their body shapes and sizes. Then ask yourself why these images or representations for men and women are most available to you. Notice how you feel about these representations, including how it feels to compare yourself to them. Imagine what it would be like for your trans clients or your LGBTQ clients to compare themselves to these images. Now bring up a picture of a trans man, a trans woman, and a non-binary person. Don't think too much about it. Just go with the first images available to you. Notice what physical or personality characteristics these imaginary figures have. Notice their racial or ethnic backgrounds. Notice their body shapes and sizes, and ask yourself why these images or representations are most available to you. Once you do that, hopefully you've paused twice now, then you can unpack what biases about gender or transgender people did you notice you have? What can you do when you become aware of these biases and how they affect your clinical judgment and practice? And how might you be neglecting to think about the wide range of trans people in the world? What effect does this have on each client who comes to work with me? And I know for me, when I do this, I usually pull up, like when I do trans men, it's usually someone with facial hair who's wearing something like a flannel, who's dressed in a traditionally masculine way. When I do cis women, it's usually someone who's light skinned and has long hair and is wearing very like appropriate clothing and like typical, like kind of like normative things. But I'm like, rarely do I pull up like a fat Black woman with natural hair. Right. So I'm like, I understand that simply having implicit bias does not mean that we're going to treat people in a discriminatory manner, but it's still important to be aware of these and to do the work to kind of decondition ourselves from what we've been taught for decades, right? Like depending on how old you are, but from the moment I was born and entered a family unit and was in the house I grew up in, I was conditioned with very limited ideas of what was normal.
Yes. Yes. Just yes.
Well, Scout, I was going to say that is such powerful work, and it overlaps with work about biases about eating disorders and body size and what a person with an eating disorder or a specific diagnosed eating disorder may or may not look like, and how we can also unpack those biases, and they all intersect, right? Gender, disordered eating, body size, fat phobia, all of it, it all intersects. So that was such a beautiful exercise. I look forward to thinking about it more.
I'm just always amazed and always enjoy conversations with you because you put things together in such an approachable way, digestible way, but with a clear, concise language. There's no verbosity. It is exactly as much as we need, and it is exactly profound enough to trigger change and to trigger inspiration of like there's more work to be done that we all can be doing, even those that, you know, we claim to be allies, we claim to be doing the work, we claim to be reducing discrimination and harm in our practices, and there's still nuances to explore. So thank you for sharing that, and I do hope everyone who listened will actually participate in that activity and take a look. Those implicit biases are, they're wicked little things. Okay, so we're almost out of time, but I want to make sure we give you all the optimization to share whatever is on your mind that you want to share with the peeps.
Yeah, I'd love to talk about minority stress model and maybe tie it to recovery capital. I think I could do that in the amount of time we have left.
Let's do
I've
it.
been tongue-tied all day. Okay. So minority stress theory was revolutionary. Prior to when this was created, there's a long history of both gender diverse people and other people in the LGBTQ community being pathologized or erased through institutions across time. Minority stress theory, instead of saying homosexuality is a disease or gender deviance is a disease, kind of positioned the problems that LGBTQI people face as originating from society rather than innate identity. This was separated into distal stressors, proximal stressors, and resilience factors. So a distal stressor would be an anticipated stressful experience, like being misgendered, being called slurs on the street, um, being refused care at a hospital because of a mismatch between ID and the way someone's perceiving you. A proximal stressor is what you do with that information. So that could lead to internalized transphobia, internalized like homonegativity. It could lead to concealing one's gender, changing the way someone dresses. And hopefully, as I explain these things, you're thinking, wow, eating disorder behaviors really fit as a way for someone to adapt their appearance or adapt their the way they move through life. Resilience factors, on the other hand, kind of counterbalance this and limit the internalized negativity, and those are typically identity pride and connection to community, which we all know is very important and should be more present in eating disorder interventions. And those resilience factors are going to mitigate some negative outcomes. I say this is connected to recovery capital. Recovery capital is a word that I first heard from Jenny Wang Hall. And I'm not sure how she defines it. I define it as how free you can be from your eating disorder under the constraints of the society that we live in and the different forms of structural oppression like capitalism, racism, et cetera, et cetera. So recovery capital would be essentially, I do this every year. I take this graphic called the Wheel of Power and Privilege. And I kind of rate where I am and score where I am on the wheel because our identities shift over the lifetime, right? I was formerly poor. Now I am not poor. I was formerly a girl and now I am an agender person, right? So like my opportunities and the impact of different structures have changed for me. So I think of that. And then I also think of things like our neurotypes, our exposure to things like minority stress, the people we could look towards for models of recovery, right? When you're talking about a very finite community or someone who has intersectional identities who very rarely sees like a Latine, small fat, queer, trans, middle class, like et cetera, right? Like we all get to honor our uniqueness, but it's important who we look towards. So like someone's point of maximal liberation from their eating disorder may look different from the person next to them based on the identities and experience values that they have. So when you think about minority stress, right? If you're always fearing leaving the house because of potential violence, that weighing on you can limit your recovery potential. And this is why it's equally as important to do individualized one-on-one treatment as it is to focus outside of these treatment and identities on changing policies and being involved in justice-oriented activities and activism and volunteerism. And these are the things that I'm hoping to highlight in the eating disorder field as underutilized interventions, right? Targeting sense of purpose, sense of belonging, and self-esteem to increase people's recovery capital.
Mm.
Yeah.
Scout, you are just a joy. It has been such a pleasure to learn from you, for you to share your expertise, your wisdom, your experience. I am just so happy to have had the chance to meet you, and we are so lucky to have you on DocTalk. Thank you for all the experience and wisdom that you have gained and freely shared to make this world a better and safer place for everyone recovering from eating disorders. And just thank you for being you.
Yeah, thanks for having me.
Yeah. We'd love to have you back. Everyone watching, yeah, enjoy your day. Like you have so much to think about now. This has been Doc Talk. I'm Dr. Erin Knopf.
I'm Dr. Corrine Hannon.
Bye.
Bye, Scout.